All right, let's talk about Barrett's esophagus. Today, we're going to break down what managing this condition really looks like. Think of it less like a complicated medical chart and more like a simple roadmap. Our goal here is to make sure you know exactly what to expect. So, let's get right into it. So, you've been diagnosed with Barrett's esophagus. I get it. That can feel pretty overwhelming, and you're probably thinking, okay, now what? It brings up a ton of questions, right? But here's the thing, and it's really good news. There is a very, very clear plan. It's not guesswork, it's a well-established roadmap, and we're about to walk through it together, one step at a time. Okay, so here's our game plan. We'll start with the two pillars of care that everyone needs to know about. Then we'll look at the two big paths you might go down. One if there's no dysplasia, and another if there is. We'll also quickly cover the question of surgery, and then we'll wrap it all up. Simple as that. All right, first things first. Before we get into any of the different paths on our roadmap, we need to talk about the foundation. Every single person with Barrett's has a management plan built on two really crucial strategies. And here they are. It's kind of like a 1-2 punch. On one hand, you've got PPI therapy. That's just a way of saying you'll be on medication to get that stomach acid, the thing that causes all the trouble in the first place, under control. On the other hand, you have endoscopic surveillance. That means your doctor will regularly use a tiny camera to keep a close eye on the tissue, just to make sure no unwanted changes are happening. So you're both treating the cause and watching the area. It's a really smart combination. Okay, so now that we have the foundation down, let's look at the first major path on our roadmap. And honestly, this is the route most people find themselves on. This is what happens when your biopsies show no dysplasia. And just to be clear, no dysplasia is great news. It means no precancerous cells were found. So what does that mean for you? Well, the plan is actually super straightforward. It all comes down to one thing: the length of the Barrett's tissue. If it's a short segment, we're talking less than 3 centimeters, you're good for a while. Your next checkup with the camera will be in 5 years. If it's a bit longer, 3 centimeters or more, they'll want to see you back in 3 years. See? It's just a simple, scheduled check-in. No guesswork involved. All right, let's switch gears and look at the other main path. This is the route you take if the biopsies do find something called dysplasia, or even just a hint of it. Now, things get a little more specialized here, but don't worry, the plan is still incredibly clear and logical. Yeah, the important thing to get here is that dysplasia detected isn't just one single thing. It's more like a category that branches off into a few smaller, very specific paths. The whole goal is for your doctor to figure out exactly what's going on so they can create the perfect plan just for you. So the first stop on this path might be a result that says indefinite for dysplasia. What on earth does that mean? Well, it's pretty simple. The pathologist sees some cells that look a little funky, but there's a lot of inflammation around, which is kind of like trying to see through a foggy window. They can't be 100% sure if it's actual dysplasia or just irritation. So think of it as a let's pause and get a better look result, not a scary diagnosis. And the plan to clear up that foggy window is really logical. First, you'll work with your doctor to really dial in your acid-reducing medication, your PPI therapy, for about 3 to 6 months. The goal is to calm all that inflammation down. Then you'll do another endoscopy. With the inflammation gone, they can get a crystal clear view and a definite answer, yes or no. Okay, so what's next? Well, maybe on that repeat scope, or maybe even on the very first one, the result comes back as confirmed low-grade dysplasia. All this means is that there are definitely some precancerous changes, but, and this is key, they're at a very early stage. And finding low-grade dysplasia brings you to a really interesting fork in the road. You've got two main options. Option 1 is endoscopic therapy. This is the proactive approach. Let's go in and remove that tissue right now. Option 2 is what's called active surveillance. This means we're going to watch it like a hawk, with checkups much more often, at 6 months, then a year, and then every year after that. So it's a big decision you'll make with your doctor. Do we act now, or do we watch very, very closely? Now for the last stop on this path, a finding of high-grade dysplasia. As the name suggests, these are more advanced precancerous changes. And at this point, there's no fork in the road. The roadmap points in one clear direction. It's time for a direct, proactive treatment plan to get that tissue out. And the treatment plan here is incredibly thorough. It's not just one thing. It's a 3-step process. Step 1 is resection. Your doctor goes in and removes any visible lesions they can see. But they don't stop there. Step 2 is ablation. They use special techniques to treat all the remaining Barrett's tissue in the area. The goal is to leave nothing behind. And finally, step 3, As soon as that's done, you start a very frequent follow-up schedule. And when I say frequent, I mean it. Look at this timeline. You're coming back for a checkup at 3 months, then again at 6 months, and again at the 1-year mark. After that first really intense year of monitoring, you then shift to annual checkups. This really is a lifelong commitment to making sure everything stays clear. Okay, there's one more thing we need to address, because it's a question that comes up all the time. What about surgery? An operation to fix the reflux itself. Does that play a role in managing Barrett's? Well, the medical guidelines on this are crystal clear. Anti-reflux surgery can be fantastic for helping with really bad reflux symptoms, the heartburn, the regurgitation, but, and this is the important part, it is not recommended as a tool to stop Barrett's from progressing. The management plan really sticks to that combination of medication and endoscopic procedures we've been talking about. Okay, let's zoom out and look at the big picture. What have we learned today? The biggest thing, I hope, is that managing Barrett's esophagus is not a guessing game at all. It is a structured, personalized roadmap based on years of evidence. So if you're gonna remember just a few things from our chat today, let it be these. 1. This is a structured roadmap, not a maze. 2. Your personal path on that map is decided by your biopsy results, nothing else. 3. No matter what those results are, there's a clear, step-by-step plan waiting for you. And 4. Proactive monitoring, just keeping an eye on things, is the absolute cornerstone of great care, no matter what. Just understanding this roadmap is a huge, huge first step. It gives you the power to walk into your doctor's office and have a really confident, informed conversation about your health. So the question isn't what's next anymore. The question is, now that you have the map in your hand, are you ready to navigate this journey with your doctor?